Don your complete personal protective equipment. For patient assessment, assess the patient using the mnemonic lemon. First, look externally. Evaluate the 3:3:2 rule, the Malampati score, and any signs of obstruction and neck mobility. The sniffing position involves a 35-degree cervical flexion with cervico-occipital extension to align the oral and laryngeal axis. This elevation could be achieved by placing a towel or pillow around 8 to 10 centimeters in height. Some have suggested positioning the patient with the external auditory meatus level with the patient's sternal notch, your EAMSN position. This is especially helpful in obese patients to move the mass of the chest away from the airway and allow space for manipulation of the laryngoscope handle. This may require placing a wedge-shaped lift, the tube elevation pillow, under the scapula, shoulders, and nape of neck. This raises the head and neck above the thorax, producing the EAMSN position and allowing gravity to pull the pannus away from the airway. Elevation of the table is also advised to avoid bending over. Ideal level of the head should be between your xiphoid process and umbilicus. A few minutes of pre-oxygenation is typically performed via a face mask attached to an anesthesia machine. 100% oxygen flow rate must be provided to prevent rebreathing. Mask is held on the face between the thumb and index finger above and below the connector, forming a letter C, as the rest of the 3 fingers are placed under the mandible for a jaw thrust technique. Due to reduction of the muscle tone as a result of general anesthesia, maximize airway patency by forward displacement of mandible. If jaw thrust fails to relieve obstruction, oropharyngeal or nasopharyngeal airway may be used. In Selleck's maneuver, an external pressure is applied on the cricoid ring against the vertebral bodies to occlude the esophagus. This maneuver reduces gastric inflation and prevents regurgitation. To open the mouth, a scissored thumb and index finger of the gloved right hand touching the right mandibular and maxillary premolars are used. Hold the laryngoscope using the left hand with the 5th finger close to the hinge and the handle pointing right of the sagittal plane. Introduce the blade along the right margin of the tongue, displacing it towards the left. Advance the blade until the right tonsillar fossa is identified. Medial to the tonsillar fossa, locate the epiglottis. Advance blade to the midline glossoepiglottic reflection. In lifting the tip of the blade, you should avoid levering the laryngoscope against the maxillary teeth, as this can damage the teeth and gums. You can avoid this problem by keeping the wrist fixed and moving the handle of the laryngoscope in the anterior-inferior direction. Insert the ETT with stylet from the right, keeping it from blocking the view of the glottis. Advance the tube until proximal margin of its cuff lies 3 to 4 cm beyond the vocal cords. Inflate the cuff with 10 cc of air, remove stylet, and connect the ETT to the bag or breathing circuit. Check by auscultation of the lungs for equal breath sounds. Auscultate before plastering the tube in place. A gurgling sound in the epigastrium would indicate esophageal intubation. Deflate the cuff and extubate. If the breath sounds are louder in the right, that would indicate a right endobronchial intubation. Deflate the cuff and adjust the tube.